Oh,
Nick,
interesting. No, I
can
can't. But don't worry. Let's go on. I can't see the slides.
You listen, don't mind him.
Oh, Nick.
No.
Okay,
Nick,
so
Okay, let me do a split screen and see.
we say that there's an impact in
Okay,
a
I can see
particular
now.
tissue. That part is an area of necrosis,
Okay.
which is resulting from blockage of the arterial supply or the venous drainage of the particular tissue. So, for example, if you have the brain and then the blood vessel supplying parts of the brain is blocked by an embolus or a thrombus, gradually enlarges and completely occludes the blood vessel, then the area of tissue that is supplied by that blood vessel will undergo ischemic necrosis because the blood supply has been cut off. And so that part will die. And when it dies, that area which has undergone that cell death by ischemic necrosis is called an infarct. So that whole phenomenon is called an infarction. Okay, so tissue infarction is common and is an extremely important cause of clinical illness. Now, pulmonary infarction can be a complication in a number of clinical settings. Then you can also have bowel infarction, that is the infarction occurring in the intestine. If it occurs in the extremities, it's called a gangrene, and this is common in the diabetic population.
Oh, gangrene.
And also, if you have it in the brain, that is when maybe patient has developed a stroke, and then that part of the brain is dead, so it can't regain its original function, but it can regain parts of it if you do physiotherapy. Now, looking at the etiology, nearly 99% of all infarcts results from a thrombotic or embolic event. So that means that a thrombus in the blood vessel will block off the blood supply, or an embolus would be mobile in the blood circulation and block off blood supply. And almost all results from arterial occlusion. Occasionally, the infection can be caused by other mechanisms. For example, if you have local vasospasms, so the blood vessel goes through spasms, it contracts and relaxes, and during that period of contraction, it shuts off blood supply. Or the extrinsic compression of the blood vessel. For example, there's a tumor that presses on the blood vessel and shuts off its blood supply. The area of tissue that dies as a result of it is also an infarct. Now, there are certain factors that influence the development of an infarct. So what are these? The multiplicity of blood supply, the rate of occlusion, the vulnerability to hypoxia, and then the oxygen content of the blood. We look at these one by one. So multiplicity of blood supply. If the tissue or organ has several...
Madam, someone is giving us feedback. Okay.
Elijah.
If the particular tissue or organ has several sources of blood supply, then it will not undergo infarction. So, for example, the liver has two sources. It has a dual supply. There's a hepatic artery and then the portal vein. And so, if there's a blockage of the hepatic artery, you will not have an infarct because the portal vein will supply blood. But on the other hand, if you take the renal circulation or the splenic circulation, they are all end arterial. When we say end arterial, we mean that it is only one artery that supplies them. And so if there's an infarct, if there's a thrombus or an embolus, then you have an infarct. The other thing that determines whether an infarct develops or not is the rate of development of the occlusion. So if the Hypoxia, sit down. Sorry. If the infarct develops slowly, then if the occlusion develops slowly, then you are not likely to have an infarct. So, for example, if you have a blood clot inside the blood vessel and it is developing slowly and slowly and slowly until it gradually blocks off the blood supply. Because of the gradual blockage, other blood vessels will develop along the line, collateral channels, and so thing is vulnerability to hypoxia. Some tissues are very vulnerable, so the least cutoff of blood supply, it will undergo death. So things like the brain tissue or the heart, they would easily succumb to ischemia. Then the oxygen content of the blood. So if you have a situation whereby the patient is anemic, it means that the hemoglobin in the blood will be low. So the patient will not have a high oxygen content. Or if you have a patient who is cyanotic, because of the cyanosis, the blood already doesn't have a lot of oxygen. And so if such a tissue, such a blood vessel carrying either anemic blood or cyanotic blood is obstructed, then the tissue will die quickly because it will soon finish up its oxygen supply. So these are examples of infarcts. You can have, this one is the lungs. So the darker area is the area of the infarct. Then this is the spleen. You can see that because the splenic artery supplies this part, you see that the whole place is pale. So that is an infarct as well in the spleen. Then this is the kidney. This wedge-shaped hollow part is the infarct, the middle portion. Okay. So I put an assignment there, but you can ignore it.
Doc, let's see the assignment.
Oh.
Thank you, madam. Thank you, madam.
Find the morphology of infarct. I mean, in this way, when I thought I had it there, that's part of the continuous assessment, but
that's fine.
Okay. So from infarct, we move on to shock. So shock is the final common pathway in a number of serious clinical events. So like hemorrhage, like burns, and so on. But what does shock mean? Shock is just inability of the blood to perfuse the organs. And it can either be because there's reduced output from the heart, or there's reduced effective circulating blood volume. And this leads to a decrease in blood pressure, then followed by a decrease in perfusion of the tissues. So the tissues don't get enough blood, and therefore they end up with cellular, which would initially cause reversible cellular injury. And then when this persists, irreversible tissue injury and death. So there are several categories of shock. We have cardiogenic shock, hypovolemic shock, septic shock, neurogenic, and then anaphylactic. So there are 5 types. So cardiogenic shock, what does it mean? Cardiogenic shock means that there's a problem with the myocardial pump. There's a problem with the heart to pump blood. That's all that it means. So if you have a patient who is in shock, who is showing signs and symptoms of shock, but this patient also has a heart problem, then it's likely that it might be cardiogenic shock. And it's very important to be able to distinguish between types of shock because their treatments are also.
Foster, please mute your microphone. Foster. Foster.
No.
You deal with the treatment when you are doing internal medicine. Okay. So, for example, if the patient has a myocardial damage, arrhythmia, compression of the heart, anything that is blocking the outflow, like a pulmonary embolism, such a patient can develop cardiogenic shock. So we move to hypovolemic shock. Hypovolemic shock means that there's a loss of substantial blood volume or plasma volume. So anything that will decrease the volume of the blood means that the blood will not, even though the heart is working well, the blood volume has drastically reduced. And so the tissues will not get enough blood. And then the body will go into shock. So things like hemorrhage, that's bleeding, or fluid loss from severe burns, or trauma, which will also lead to bleeding. diarrhea, vomiting, anything that decreases the blood volume or the plasma volume would lead to hypovolemic shock.
Okay.
Then we have septic shock. So septic shock is caused by systemic microbial infection. And I must say that this is severe infection and usually commonly occurs in the setting of gram-negative infections. So notably, gram-negative infections are much more serious than gram-positive infections because they usually lead to septic shock. We can also term them as endotoxic shock. It can also occur, septic shock can also occur with gram-positive infections and fungal infections, but most commonly it occurs with septic shock, with gram-negative organisms. Then we have neurogenic shock. So neurogenic shock is not so common, and it usually occurs in the setting of an anesthetic accident or spinal cord injury. What happens is that there's loss and this leads to peripheral pooling of blood in the veins. So what does this mean? Usually the blood vessels have a certain tone. Tone is something like they have a certain capacity. If they undergo vasodilatation, then there'll be pooling of blood and the blood will just sit there. But there's some sort of vasoconstriction that occurs so that the blood will be moving about. When there's dilatation, the blood will just sit. It's like it sits for a long time. The blood will pool in the veins and it will not be available all around for circulation. Then we have anaphylactic shock. So anaphylactic shock is also associated with a systemic vasodilatation. Now, this systemic vasodilatation would lead to increased vascular permeability. So, because of the increased permeability, there will be leakage of fluid from the blood vessel into the interstitial space. What this means is that the volume of fluid and blood inside the blood vessel will decrease. And this is what will lead to the anaphylactic shock. It is usually initiated by IgE-mediated hypersensitivity response. So this can occur, for example, people who have a severe reaction to maybe granules. So when they chew the granules, they have this severe reaction, which leads to vasodilatation, there's pooling of blood, and then they go into shock. So for such patients, usually they carry an EpiPen or something with epinephrine. So you just inject it and then they'll be fine. Okay.
Doc, you mentioned people who react to groundnuts.
Yes, so it's like a form of allergic reaction.
Allergic. So is it just the groundnut or any form of allergic reaction that leads to?
Any form of allergic reaction, any form of allergic reaction, bee sting, pollen, whatever. Okay. They go into severe, they can actually go into shock. So this is a severe form of shock.
Okay.
So I decided that we'll take septic shock and look at it critically because septic shock is not very common, but it is the most severe form of shock. And it has a very high mortality rate, 25 to 50%. And because it's associated with severe infection, usually it is the commonest cause of death in intensive care units because patients in intensive care are severely ill. And the incidence is increasing because now you have very sophisticated machines in the intensive care. So they have improved life support for high-risk patients. Patients who would have died ordinarily can now be supported. And then they are now prone to very bad infections. Then there's increased invasive procedures. You have central line, you have catheters, you have things that would now introduce pathogens into the circulation. Then there's increased number of people who have immunocompromised immunity. So, for example, patients with HIV, people with immunosuppression, chemotherapy, and so on. And for septic shock, what happens is that there is a widespread there's a spreading of a localized infection throughout the systemic circulation. So, for example, patient has a pneumonia, has peritonitis, has an abscess, and then it spreads into the rest of the bloodstream. Most of the time, about 70% of it is caused by gram-negative bacilli. And so these gram-negative bacilli, they produce a chemical called endotoxin. And so that is why septic shock is also termed endotoxic shock. And this endotoxin is from the bacterial wall lipopolysaccharide. I'm sure you've done cell structure, and you remember that the bacteria has a cell wall which is made up of lipopolysaccharides, meaning
Yes, madam.
that both it is
Yes,
both
madam.
lipid and then carbohydrates.
Yes, madam.
So what happens when you have an infection with a gram-negative organism? The gram-negative organism has its bacterial cell wall comprising of the lipopolysaccharide. Now, this lipopolysaccharide is made up of two things. The lipid part, which is called lipid A, is a toxic fatty acid molecule. And this is complex to the polysaccharide coat. And that polysaccharide coat is unique for every organism. And it's called the O antigen. So bacteria, gram-positive bacteria, fungi, they can also have this, but then to a lesser extent. Okay. So what is so unique about the lipopolysaccharide? The lipopolysaccharide contains the lipid core and then the polysaccharide. Now, this lipopolysaccharide will attach to a protein in the blood called circulating LPS binding protein. So it will bind to the LPS binding protein and it will form a complex. Now, this complex will now look for monocytes, macrophages, or neutrophils in the blood. All these are white blood cells. And if you remember, the white blood cells from inflammation, they are the ones that help to fight off infection. Yeah. But see what happens. The gram-negative bacteria has a lipopolysaccharide in its cell wall, binds to lipopolysaccharide binding protein. And now it's this lipopolysaccharide binding protein plus the lipopolysaccharide will go and bind. Please give me a minute. Sissy, where do? Okay, yeah, then I'm Patrick, me Zoom lecture, me for a while. Love you. Bye. All right. Okay.
Nekatawaso. Where you are from TV?
And you know, I can meet Buju Banton, Psalm 23. One of my favorite songs.
Yes, Psalm 23. Yes, one of my favorite songs.
Yeah.
That's my ringtone now. Okay, so where were we? So the lipopolysaccharide will bind to the lipopolysaccharide binding protein. And then this complex will go and look for monocytes, macrophages, and neutrophils. Then this complex, after it binds to the macrophages, monocytes, and neutrophils, it leads to intracellular signaling. And you need very small doses of this complex, as small as 10 picograms. 10 picograms is like 10 to the power minus 12. So such a tiny dose can lead to the engagement of the CD14 cells, which are part of the immune system, to produce cytokines, interleukin-1 and tumor necrosis factor. And these interleukin-1 and tumor necrosis factor, they are the ones that will lead to the severe pathologic changes that will cause a shock. So the TNF1 and interleukin-1 would go on and cause production of interleukin-6 and 8. And these ones would produce a massive inflammatory response. It will also activate complement, which will help to eradicate the bacteria. But because of the effect that has occurred, it becomes like a cascade effect. So let's look at it. You have the LPS being produced. It complexes with the LPS binding protein, and it leads to the binding to monocytes, macrophages, and neutrophils. Once it does that, it causes the production of TNF and then interleukin-1 through intracellular signaling, leading to production of interleukin-6 and 8. And this interleukin-6 and 8 are the ones that will produce the massive effects. So the tumor necrosis factor and interleukin-1, they produce fever, they lead to increased secretion of acute phase reactants, and then increased production of neutrophils. Now, this also leads to systemic vasodilatation, and the vasodilatation is what will cause hypotension. These same cytokines will also decrease the contractility of the heart, and then they will also cause injury to the endothelium of the blood vessels. And this is a generalized widespread thing. Okay, then it also causes leukocyte adhesions and then damage to the lungs. So this small endotoxin from the gram-negative bacteria will lead to all these problems. Now, this is what will happen. The hypoperfusion would be from the widespread vasodilatation. Then there will be a depression of the heart. So you have a pump failure as well. And then you also have activation of the clotting cascade, which will lead to a DIC. So all these things would occur in all the organs in the body. So this leads to a multiple organ failure. So eventually the patient will die. So when you have large quantities of the lipopolysaccharide, you have septic shock. If they are moderate quantities, you have systemic effects like fever, like hypotension and all that. And if they are small quantities, then you have local inflammation. So having looked at septic shock in general, we'll go back to, having looked at septic shock in particular, we'll go back to shock in general. So when a patient goes into shock, there are stages. It is progressive. There's the initial non-progressive stage. Then the shock progresses. Then you get to the irreversible stage. At that point, no matter what you do, the patient is on their road to dying. Okay. So the initial non-progressive phase, there's reflex compensatory mechanisms. And so the body is still trying to compensate. Then if this compensation fails, then you start progressing towards a situation whereby there's decreased perfusion of the tissues and there's worsening circulatory and metabolic imbalances. If nothing is done at this point, you get to the irreversible stage where the body has now gotten to a stage of increased cellular and tissue injury, so that even if at that point you do something, survival is not possible. So what are the things that are present in early shock which help to compensate the body? So there's release of catecholamines. We know what catecholamines are, epinephrine and norepinephrine. Then there's also activation of the renin-angiotensin axis. Was it yesterday that we mentioned the renin-angiotensin axis?
That was on
Saturday.
Saturday.
Yes, okay. So what we said was that when there's decreased perfusion in the kidneys will sense that there's decreased blood volume, and they will cause the secretion, the production of renin from the juxtaglomerular apparatus. This renin will lead to the production of an angiotensin, and angiotensin will also lead to the production of aldosterone. What aldosterone will do would be to cause sodium reabsorption. So wherever sodium goes, water will go. So it will it's trying to beef up the blood volume. Okay, so shock is a situation whereby there's decreased perfusion of the tissues because the blood volume has gone down. So all these mechanisms are trying to beef up or increase the blood volume. So we also have antidiuretic hormone release. What antidiuretic hormone does is to concentrate the urine and to cause fluid retention. What it does is that instead of the kidneys letting go of water, it keeps the water, and so the urine becomes concentrated. And this it does in order to try and increase the volume of the blood. Then generally there's a sympathetic stimulation so that you have vasoconstriction. The vasoconstriction. So in early shock, all these things that we talked about will lead to a tachycardia, that is increased heart rate. Then you have peripheral vasoconstriction, and then renal preservation of fluid. So the patient will now pass scanty urine because the antidiuretic hormone is trying to conserve water. Then you have peripheral vasoconstriction from sympathetic activation from the catecholamines. Then you have tachycardia, that is increased heart rate. Hey, the meeting will end in 10 minutes.
10 minutes. Don't worry.
We'll restart. Okay.
Yeah.
So the vasoconstriction that occurs is what is responsible for the pallor of the skin. So that any patient who is who has vasoconstriction, you see that the skin becomes pale and then it becomes cold, because if you have vasoconstriction, it means that the blood has moved away from the skin, and so blood is warm. So once the blood moves away, then the skin becomes cold, and so the patient has a flushed skin. Okay. So progressively, if this is not corrected, the shock gets into the progressive stage, whereby now we are trying so hard to increase the blood volume. I guess to a point that if the blood volume is not helped by external forces, maybe if you are hemorrhaging and you stop the hemorrhage and you transfuse with blood or you give IV fluids, if none of these things happens, eventually what will happen is that there will be decreased oxygen. So there will be hypoxia throughout all the tissues. And this decreased oxygen would lead to the aerobic, switching from aerobic respiration to anaerobic respiration. So that will lead to the production of lactic acid. The lactic acid would lower the blood pH and will also cause the arterioles to dilate. Once they dilate, the blood will pool in the microcirculation, and this pooling of blood will further decrease the blood pressure. Okay, so once this continues, you realize that then the organs start to fail. The patient might become confused, and then when the kidney starts to fail too, the urine output will decrease. So eventually, the patient will enter into an irreversible stage, whereby there's widespread cell injury throughout the whole body. The heart contractile ability will also decrease, and you'd realize that there will be the tissues will not be able to perfuse very well. So then you end up with renal shutdown. So morphologically, shock affects all parts of the body, and it can affect the heart, whereby you would have a focal and widespread coagulation necrosis, or it can lead to irreversible injury. You can also have the lungs, but usually in the lungs, because there's a lot of air, you don't get that hypoxic injury until it is very late. So you have, what you see is that there'll be diffuse alveolar damage, and this is called the shock lung. Then the adrenal glands too, you see that there will be depletion of lipids in the cortex of the adrenal gland. Then in the brain, the patient will develop ischemic encephalopathy, and this is what will lead to the confusion. In the kidneys, they have acute tubular necrosis, and that's what leads to decreased urine output and electrolyte imbalance. It can even lead to renal failure. The GIT, you have patches of hemorrhage and necrosis, and the liver can develop fatty change. So clinically, as this progresses, the patient, so initially the pulse is high, there'll be a tachycardia, but as it progresses, you'd realize that now the heart rate will slow and it will be weak. and the patient will start breathing fast because of the changes that will occur in the lungs. Then the skin will become cool, clammy, and cyanotic because there's vasoconstriction. So the blood moves away from the skin. Okay. Eventually, the patient would develop changes in the circulation, in the brain, in the heart, in the lung, and this can lead to problems in the liver, in the kidney as well, and it can eventually lead to death. But if the patient survives this initial phase, they can enter a second phase whereby there's renal insufficiency and a progressive fall in the urine output. So in terms of prognosis, the prognosis is very bad and it depends on the type of shock anyway. If the patient has hypovolemic shock, once you correct it with fluid, they are fine. But something like cardiogenic shock or septic shock, they have very high mortality rates. So you realize that when you have a patient in shock, clinically, you need to pass a catheter because you want to monitor the urine output, because the urine output can also go very low. Okay. So if there are any questions, that's the end of the slide.
Oh, okay.
Any questions?
Evans, today you have to start asking questions. Baby.
Okay, madam, I came in late, but I saw something like gram-negative shock. I don't know what it is.
Gram-negative what?
You came in late and you saw gram-negative, that's all.
You said you saw something like gram-negative what?
Nick,
Something
Nick,
like
Nick,
gram-negative what?
no, you're not one class.
Hold on. Let him ask his question. Jefta, come again.
You said you saw something like gram-negative what?
Shock or something from the last slide.
Gram-negative what?
You can't gram-negative. No.
Gram-negative shock.
No.
Yes, so we have gram-negative shock or endotoxic shock. It's also a type of shock. It's part of the septic shock. So septic shock is the kind of shock that is caused by bacterial infection.
Oh, okay. So that one is caused by like bacterial infection.
Yes, and usually gram-negative bacteria.
Oh, okay. Okay.
Yeah.
Mama Esther, you had a question?
No, I wanted to ask if the patient's shock is progressing, whether you can see it. But upon thinking about it, I think you can see it.
Yes, you can, because you realize that the patient will become confused. The urine output will decrease and the skin will become cold and clammy. So that will tell you
madam.
the shock is progressing. Yes.
Solomon.
Madam, please, can I talk? Yeah. Please, because about the gram-negative bacteria, is it because they have more of the polysaccharide, that is why they are more dangerous as a result of their
Yes. Yes, they have the lipopolysaccharide, and that is what causes the problem.
Okay.
Danny, your hand is up. Ask your question. Unmute your microphone.
Okay. Madam, good evening. Would you? I would like you to go over the shock process again.
Danny, your hand is breaking.
You want me to go over what?
The shock, the volumetary shock, the shock, the whole thing, like
the whole thing.
Like the shock.
The whole thing.
No, the shock process. No, the shock process.
The shock process.
Something like in the summary form.
You see, when you join late, that's what happens. So you miss out on everything. Very difficult.
I am a Madam Major, Danny.
Specialist.
So what happens in shock? So shock is a situation whereby there's decreased availability of oxygen to the tissues as a result of decreased availability of blood. Okay, so there's decreased perfusion to the tissues, and the tissues, the blood that is coming to the tissues is what is carrying oxygen. Are you following? So this can occur either there's a problem with the heart, so the heart is not able to pump the blood to all the tissues, or there's a problem with the circulation, and so the volume of blood is decreased, or the blood is there but it is sitting in the veins and it's not circulating. That's what we call peripheral pooling of blood or vasodilatation. Okay. So these are the three things that will lead to shock. And the main thing that happens is that when you have the shock,